very pleased to continue the On the Issues series. And today's conversation is with Dr. Chima Ndumele. He is a member of the Yale School of Public Health Department of Health Policy and Management, a department with very special interests in the American health system and how it might be improved, both for efficiency and effectiveness. And Chima and I are friends, colleagues in the school, and I thought we'd ask you to start, Chima, by telling us a little bit about Medicaid, your area of special expertise.
Sure. Medicaid is the primary vehicle for coverage for low-income families in America, covering about 77 million people annually. Despite the fact that most people relate Medicaid coverage to the low-income group, it also covers the elderly, disabled, children, as well as pregnant women.
That is a good reminder, and we always think of Medicare as the only vehicle for covering the elderly, but a subset of elderly are also covered through Medicaid. I think Medicaid was created with the commendable goal of helping low-income persons in the U.S. access health care. And do you think Medicaid is performing well at the present time in the context of the Affordable Care Act having expanded coverage in a number of states?
So by and large, all reports suggest that the Medicaid program is performing well. Medicaid has been a reasonable vehicle to expand coverage to people without any clear detriments to access or quality of care. Surveys of individuals enrolled in Medicaid suggest that more often than not, they are excited about their coverage. There are, however, fiscal challenges with the Medicaid program. While the Medicaid program has been traditionally a state and federal government partnership, where the federal government covers about 50 to 75% of the costs. Recent proposals have sought to transform the Medicaid program to either a block or per capita grant program. In theory, that would provide a little bit of financial budget predictability for the federal government, a bit more risk for states, but inevitably lead to less people getting covered in the program.
So that's very interesting, that fewer people are going to get covered in Medicaid if we go to block grants. Could you tell us why that might be the case? Because I've heard from congresspersons speaking on the television that the same amount of money is going to be going into it.
So one of the important features of the traditional Medicaid program is as the program expands, the federal government remains responsible for the portion that it pays for. Under a block grant system, the rate of growth of the program may not match the rate of spending increases that the government provides to states. As a function of that, the Congressional Budget Office has predicted that a block grant program would lead to 25% decrease in government spending in the program over the next 10 years, and about 15 million fewer people covered.
Okay. Now, you've done some recent research on Medicaid and published it in one of the AMA journals that talks about potential instability in health markets, and I think in some ways your results were surprising. Could you tell us about that?
Sure. So about 80% of individuals in the Medicaid program are enrolled in a part of the program that we call the managed care program. Under managed care arrangements, states contract for a flat fee directly with private insurance plans, and those insurance plans in turn contract directly with the network of providers that are designed to facilitate care for enrollees. We find that the relationship between states and these insurance plans is tenuous at best. That over the course of about 8 years, over 100 insurance plans left the market, dissolving the partnership between states and plans. As you might imagine, this is a challenging prospect for individuals who may have to find new physician in a new insurance plan, who have to go to a plan that has a different administrative structure and a different focus in it as it relates to quality improvement. It should, however, be noted that when we look at the relationship between plan exit and quality of care, we find that the vast majority of plans that leave a market are lower performing than the plans that remain in the market, and that the effect of a plan leaving a market is minimal in terms of its impact on patient care and the quality of options that remain for patients.
Well, that's very intriguing because for me that's a little counterintuitive. I think about the more plans we have, the better. But you're saying market forces are essentially deleting underperforming plans.
Yeah. Well, this is informed by the broader conversation that we just had about the recent Republican proposals. One of the things that we find in our study is that despite all of the plans that left the market, they were often, almost always, replaced by new plans that wanted to come in because the Medicaid program was a desirable product that plans wanted, a desirable market that plans wanted to compete in. One of the challenges with decreasing the amount of funding that is available for the program is that it will become a less desirable product for plans, which will lead to decreased competition and all of the challenges that you alluded to.
All right. Well, let's talk about the Affordable Care Act for a moment. It's in flux, remains uncertain. Almost a majority of senators want to get rid of it. Not quite, which is why they haven't gotten rid of it. What do you foresee happening to Medicaid in the near future, which is a vital part of the Affordable Care Act and preexisted it, and it seems to be an anchor for, as you say, 77 million Americans?
So I think the program itself is stable. As I mentioned previously, there are enough constituents and enough groups of people that are impacted by the program that it has really become part of the fabric of our insurance system. I am, however, concerned that the reforms that are proposed will start to erode the access to care that individuals have, the desirability of the program for physicians and their participation, and finally, whether plans think that they want to continue providing care in this market.
How could policymakers better structure the Medicaid program?
Yeah. Primarily by learning from other states. It turns out that despite the fact that we talk about the Medicaid program as if it's one large system, it really is 51 programs facilitated by 51 different states. States are doing incredible experiments all over the country, and they should really serve as laboratories for other states to figure out both what works and when it works. I think there is an incredible opportunity for peer-to-peer learning in the Medicaid program.
Speaking of learning, I've learned a lot, Chima, and it's gracious of you to do this. We're very proud that you're a member of our faculty, and thanks very much for your time.
Thank you. My pleasure.